Thanks very much. Thanks for the invite, Huey and Dr. Quinones and Carla and everybody else. Always good to be back here. No talk on surgery would not be complete without an overview of the anatomy, and that's the first important thing. I mean, you guys, as cardiologists and as cardiology trainees, will be counted upon to show us exactly what we need to do before we get in there. And I'm not going to go over a lot of the indications for surgery or some of the outcomes, because a lot of that has been covered by the previous speakers. I mean, that's really what's most important for you to know, as to when to refer, how to refer, and what's the indications of when to do this. But if you look at the mitral valve, for example, just focusing on the anatomy, 2/3 of the anatomy of the mitral valve of the perimeter is covered by the posterior leaflet, whereas the anterior leaflet only covers 1/3 of it. Okay, yet the area is covered 2/3 by the anterior leaflet. So that's the biggest functioning portion of the anterior leaf of the mitral valve, with two papillary muscles giving chordae tendinate to both leaflets on both sides. So the anterior lateral, and the posterior medial papillary leaflets there. The mitral valve is divided into scallops, right? So the anterior leaflet has scallops that are on the top, 1, 2, and 3, going from left to right, and the posterior leaflet as well. So when you describe these on the echo, you clearly want to give the type of mitral valve regurgitation, but also if you can pinpoint it to a particular area, a cleft between one or two of the scallops, or a particular scallop that is prolapsing or annular size. These are all things you want to be careful about in terms of identifying for a description of the anatomical pathology. It's very important to also note that the mitral valve and the aortic valve are in close continuity, right? So the aortic mitral continuity is one big structure, and you can see here that when we look at the aortic valve and we replace the aortic valve or repair it, and we do aortic root surgery, the mitral valve is right underneath, right? So if there's continuity between the aortic and the mitral valve, the non-coronary and the left coronary cusp, right underneath that is the anterior leaflet of the mitral valve with conduction tissue right in that area. So when we do TAVR, for example, transcatheter aortic valve replacement, and the valve sits a little bit lower beneath the aortic valve, as would be expected to get a proper anchoring of the valve, then it's not uncommon for these patients to require pacemakers, because you're impinging and you're putting radial force on the conduction tissue. This is another view of what I just talked about. So these are the scallops of the anterior leaflet and the mitral valve and the posterior leaflet. Again, when you describe these to the surgeon who will be coming back and knocking on your doorstep to see how he can plan for his operation, these are all the things to look for. Another anatomical considerations here, you see not just the membranous septum, but also there is the circumflex artery, which lies right behind the posterior leaflet of the mitral valve and the posterior annulus, as well as the coronary sinus, which is also in close proximity. So you have the commissures, you have the leaflets, you have the aortic valve, you have the annulus, all things that can impact on the mitral valve function, as well as the LV function itself as you pull back. And this is an important aspect to look at, because it's like comparing cancer, breast cancer to colon cancer. They're just not the same disease. And if you look at this, there's functional mitral regurgitation and there's organic mitral regurgitation, okay? This was touched upon a little bit, and those, whether you operate on these and when to operate on these, or whether to, and how to treat them, is really depending on which of these pathologies you have. Organic disease is a very, it's very readily repairable and usually has a good prognosis if you fix that. Functional mitral regurgitation, on the other hand, is more of a ventricular problem, and it's still up for debate in terms of when and where and whether you should need to repair that at all, as opposed to have the heart failure option. So there's three types, there's Carpentier, a famous surgeon, has taught us that there are three ways in which we can classify mitral regurgitation. Type 1, normal leaflet motion but dilated annulus. Number 2, leaflet prolapse, if you have one or either of those two leaflets that's prolapsed. And number 3, you have restriction on one or two of the leaflets, commonly seen in rheumatic disease. You can also see that in MI patients who have tethering of one of the leaflets, for example, with the restriction in either systole or diastole, so type 3A or type 3B. And then obviously the annulus is also a common culprit in all this. As the ventricle dilates, that may cause more MR, and that causes a significant problem there. So I'm not going to go through a lot of this, but really the punchline of the data is that the earlier referral, if you have severe MR, the better, because then you impact on their survival. and even after you fix the valve, because you allow for prevention of the ventricle and pulmonary hypertension and all the sequelae of long-standing mitral regurgitation. The other thing is that functional MR has very good prognosis, but in organic MR has very good prognosis. But functional MR, on the other hand, with poor LV function, may improve symptoms, but does not necessarily improve survival. So this is what I mentioned in terms of having the true disease affected and the true disease delineated, whether it's organic or functional mitral regurgitation. I'm going to skip through a lot of this. There's been a big change in terms of how we choose which valves these patients get. Clearly for mitral valve regurgitation and mitral valve surgery, we always try to repair the valve. And there are surgeons who are more expert in this, so obviously you would need to seek out a surgeon who's expert in mitral valve surgery. But if the need to replace the valve is there, and in many cases that may be the better option rather than a suboptimal repair, oftentimes you can see this is based on the STS database, and this is over a decade ago, even before transcatheter procedures came up. The mechanical valves are going down, tissue valves are going up, and that's basically because the need for reoperation surgery is a lot more tolerated now, rather than putting these patients on Coumadin and the problems that can arise from long-term, lifelong anticoagulation. So more tissue valves are being used than mechanical valves. Need for this is clearly LV dysfunction and symptoms. So I'm just going to skip through that, class 2A and 2B indications. The way that we approach this, now this is the fun part where we talk about the operation. Most surgeons approach the mitral valve through, obviously you need to be on heart-lung machine, bypass surgery. You do bicaval cannulation, so you cannulate the superior vena cava and the inferior vena cava. You can see that here. This is the surgeon's view. So the top of the head is on the left, the bottom of the patient is on the feet is on the right. You have the SVC on the top, IVC here, so you have two cannulas that are draining both the SVC and the IVC. You have the aorta, which has been cannulated to return the blood that's oxygenated from the heart-lung machine. Then you isolate the heart-lung by putting the clamp on and stopping the heart with cardioplegia and high potassium solution. Most people would approach this through a left-sided incision. So like you see here, we would open up the left atrium in Watterson's groove between the left and the right atrium. The right usually is on top, we call it the right, but it's usually above the left atrium. And then you have a clear access to the mitral valve here, and that allows you to have a good view of the mitral valve. Now, once you get there, the first thing you do is to confirm the pathology that you have based on the imaging that you saw previously. And oftentimes, the most common operation I'm going to address that usually is usually some kind of posterior leaflet prolapse for organic disease. You can have anterior leaflet. Either way, most of the time you would either put a new cord, like you see on the right side here. So this is a more common operation now. This is becoming the standard of care, where you go in, you put cords on the mitral valve leaflet, and you replace either an elongated or a ruptured cord, either on one or more of the scallops of the mitral valve, and that's why it's important to identify those ahead of time. If you have a cleft between one or both of the scallops, you can close that as well. Or if you have the Carpentier approach, which is to resect the organic disease, and by resecting that, then you close it up and then you prevent the prolapse of that leaflet. Usually that's performed on the posterior leaflet. A lot of the data has shown that if it's a posterior leaflet anatomy problem, then resection is usually a better approach. If you have an anterior leaflet problem, then usually new cords is the better approach, and that's usually a lot more easier to do, and it has very good long-term results. So there's a variety of techniques. I'm not going to go through all of them. The patients have full fellowships that look at mitral valve repair, but basically you can resect leaflets, you can address all types of bands and annular remodeling procedures, but all of these, and vast majority of these, can also be done through minimally invasive approaches, and rather than simple, straight, the usual standard sternotomy procedures. And this has been going back and forth, but usually most procedures now in most centers are either done through a sternotomy, for example, if you need coronary bypass or multi-valve procedures, or through an anterior lateral thoracotomy for a minimally invasive approach. Robotic procedures have really come, and they're really isolated to just a few centers in the country that do some of these, but really the long pump time and the clamp times have become prohibitive and are not necessarily much better than the anterior minimally invasive approach that is done through a right-sided chest approach, which can be done usually through 2 or 3 hours, just as quickly as a sternotomy approach. So I'll show you some of this. Clearly, we talked about the valves. These are some of the sutureless aortic valves that are now on the market, and they're pretty common. What they do is that instead of suturing the aortic valve to the aortic valve to the annulus of the valve, you can just go in, and this would become a self-expanding prosthesis. You go in and you deploy it, and through the radial force, just like a TAVR core valve, for example, that I'll show you, the valve is held in place, and the hemodynamics of these valves has been shown to be quite a bit better. So this is what a procedure would look like if you're going for the mitral valve, and you can see here that you're able to get access to the left atrium and open that up and have the exact same operation. And this is a video of that exact same procedure of one of my patients. We're doing a small 5 to 6 centimeter incision underneath the right breast. You can see here, again, the head is on the left, the feet on the right. Pericardium has been opened. The purple structure is the right atrium. This is the SVC with the swan peeking right through the SVC over here. We dissect out the left atrium from the right atrium. The aorta has now been cannulated. This white structure is the aorta. The heart now is decompressed. Okay, the blood's gone, and you can see how it's more collapsed. The left atrium now is opened, and we have a clear view of the mitral valve that we can interrogate and try to assess and confirm the pathology that we have. And this is what the surgeon can do. And this can all be done through a less invasive, minimally invasive approach, which has been shown to have obviously less blood products, transfusions, quicker recovery, and less hospital length of stay. In this particular case, the patient had a posterior leaflet prolapse. We put our annuloplasty sutures around the annulus of the mitral valve. We pressurize the ventricle, and you see those two white cords over here are cords that we've placed for a prolapsing leaflet, and then those are tied at the very end in order to measure the exact length of those cords to make sure that we get rid of the prolapse. And then once we have that, I'll fast forward this, you have the ring in place, the mitral valve has been pressurized, and you have a pretty good result, and the cords are tied. And this is the final product. You have a valve with no leaking unless you put the plastic sucker across that. So this is a common operation. We do this relatively routinely. This is what it looks like in the operating room through a less invasive approach. Usually 5 to 7 centimeter procedure, and this can be done for both aortic and mitral valve procedures, and patients generally do quite well. This is a Barlow's valve where you have bileaflet prolapse and extensive leaflet prolapse of both with extensive tissue, and that can also be repaired through a combination of one of the two procedures that I mentioned of resection, as well as annular remodeling and new cords. And this is what the echo would look like. This is what you see here preoperatively. You have the posterior leaflet prolapse, and then this is on the 2D, and then you have the final product should be no MR, because early residual MR after the surgery is always going to be a predictor of long-term MR, and it's very important that we leave the operating room with 0 MR or as close to that as possible after the surgery so that we can have long-term durability and good outcome. The other way to assess good long-term outcome is by the co-optation depth. So if you look at the anterior leaflet and the posterior leaflet, you would want to have a co-optation depth between those two structures at the end of the surgery of at least 5 to 8 millimeters. If the leaflets are just barely touching, then that's going to predict, while you may have a competent valve at the time of surgery, that's going to predict recurrence later on. So it's very important that we have that, and that's one of the things that we look for with cardiac anesthesia and cardiology when they look at the echo during the operation before we close the chest. So again, one of the main things that we look at, endocarditis. I'm going to transition now in the last stage to percutaneous technology. There's a lot of movement in this area. This is billions and billions of dollars are being spent on this. Aortic valve therapy has been transformed with TAVR. 2 of my days every week now are spent in the hybrid room doing TAVR and MitraClip procedures. And clearly those are things that were just not available just a few years ago. The 2 valves that are currently on the market, there is SAPIEN 3 and the Medtronic Evolute valve. Very different in how they look, but they both achieve the same purpose. They're both available through 14 French devices from the groin. And they're both available for extreme risk, intermediate risk, up to intermediate risk indication, which recently became approved. And there are currently low-risk trials for all comers, basically low-risk patients that would be referred for aortic valve surgery, for aortic stenosis, randomized to either surgery or TAVR, with both of these valves currently going head-to-head. So this is the Medtronic valve. It's a self-expanding prosthesis, which really pushes on the outskirt, on the annulus and the native valve. The other valve, the Edwards, is a balloon expandable valve. So you can see how they're very different in how they're deployed. And this also is a shorter valve, but clearly you need a lot more pacing for this valve. You would pace during the operation, and in order to deploy that at the right annular location. So once you have that, this is an extensive workup for a lot of these patients, a lot more than we used to do for surgery. Multidisciplinary evaluation, you need to have several specialties. Oftentimes they're very sick, multiple consultations, you need good imaging. CT scan is becoming the most important way to assess these and size the valve. A lot of these complications that can happen with TAVR have been minimized, and a lot of them have really become less than 1%. And a lot of it is based on the anatomy. So I'm going to skip through that a little bit, but really pacemakers we talked about because of the conduction tissue. You can have leaking across the valve, and that's part of the improvement in the technology. We now have sealing skirts around these that improve the overall residual leaking. Coronary obstruction is always possible. You can have that from the native leaflet that is obstructing the coronary artery. Again, the chance of that happening is less than 0.5% because of appropriate prevention and assessment. This is the infamous iliac on a stick procedure. Again, we rarely see that. Sometimes occasionally you see minor leaking from the peripheral stick, but other than that, it's relatively low. You want to minimize all of these complications for good outcome. And the partner study is the first one that showed us how good a lot of the TAVR can do for patients who are inoperable. And it's really amazing technology that has come to us. And it's worked its way already into the guidelines, where now there's Class 1 and Class 2A indications for use of TAVR in a very short period of time. So I'm going to skip through a lot of this. Mortality and stroke of 1% or less. So excellent results with TAVR these days. And it's, it's very recently, it's very humbling that it's been shown to be even better than surgery, which is the gold standard still in many of the high risk and extreme risk populations. And now, like I said, it's even approved for moderate procedures. But nevertheless, after 500 cases of TAVR, this is a patient that we had, did very well. Everything was going. We had conscious sedation, where the patient was actually awake while we do this. And then you see this potential complication right there, where you have a significant aortic rupture. Okay, and this is what I'll close off with, because it's important to know that while these procedures do great and patients can go home within 24, 48 hours, and oftentimes we get these procedures while they're awake, this is a relatively intermediate risk patient that we did. And one of the leaflets, as we inflated the balloon to pre-dilate the valve, piece of the calcium from the native leaflet, before we even put the valve, ruptured the aorta, right? And it was like a sort of a stagger, a stab wound to the aorta right around the right coronary artery. Luckily, we had all the preparations in place, and that's why it's important that this becomes all the preparation need to be there in order to have a good, successful program. And that's what distinguishes good programs from bad programs, is that we identified the hole, we put the patient on pump within just a couple of minutes, and then replaced the valve surgically, and he walked out of the hospital in 6 days. So the take-home message here is that while they're pretty straightforward procedures, and they do quite well, you have to be prepared and always be on guard. And I'm going to skip through that. These are available also for valve-in-valve procedures, and they're approved for that. And the gold standard right now is less trauma. It's a safe, awake, percutaneous transfemoral approach is the standard of care for most of these. If that is not a possibility, then we have a low threshold for doing alternate access through the subclavian or direct aortic procedures, and patients generally do quite well, and until we get low-risk patients. I'm going to skip through that, but transcatheter mitral procedures are coming up, and they're in trials right now for feasibility, and closely we're going to be starting with pivotal trials. And you can see here it's a little bit more challenging. The anatomy of the mitral valve is a lot more challenging for transcatheter procedures, but this is one of the valves that's going to be looked at. It's called the Tiara valve. This is now all deployed through a transapical approach, where we make an incision down the left chest right at the apex of the valve and put that in while the heart is pumping. And you can see here that the leaflet skirt is attached to the aortic, the atrial side of the valve, and it immediately starts working. Now, of course, you have the LVOT right there. You don't want to obstruct the left ventricular outflow tract. You want to make sure that you don't have MR across the valve. So there's a lot more gadgetry, a lot more things that need to be taken care of, and it's a lot more difficult to do this for transcatheter valve in the mitral position than the aortic. And that's my 10-minute spiel. Thanks very much.